Hello, and welcome back to Chapter 9 in Law and Ethics. We're starting on page 192 with Section 9.5. We only have 3 slides left in our slide deck, but there is a lot of information in these last 2 sections. So, in the first section, we're going to talk about identification and retention, and in Section 9.6, that starts over on the bottom of 197, we're going to get into the disposition, and that whole last section is talking about record disposition. Now, at the top of 192, it talks about sound policies and procedures for the identification, retention, and disposition of health records is vital, especially when we're talking about litigation, regardless of what your record format is. So, in essence, your organization has to know where the information is housed, how long it should be retained, and when and whether it may be destroyed. It's important for the retention policies and procedures to address the legal health record, but you got to think about those other sources of information. So you've got backup tapes, voicemail, word processing drafts, shadow records. Now, when your organization is ready to replace an EHR or upgrade a paper record to an EHR, you have to consider your policies on the accessibility, retention, and the destruction of your information. Now, dropping down in the health record identification. So, when that patient first comes into the facility, their very first encounter, they are assigned a unique identifier. Typically, this is your health record number or your medical record number, whatever the terminology is that your facility will use. Now, this is where we actually start the process of gathering the registration information. So we're getting your name, your address, your birth date, your insurance information, and so on. Now, depending on the size of an organization and the number of patients treated, the patients usually assign that unique identification number, which is essential to future record retrieval. So if they come in 2 weeks later, we know that they've been there before. We can look them up by name or look them up by a social security number, look them up by a birth date, and we'll find their information, and we can continue recording their information under one medical record number. So, the initial information becomes a part of the facility's master patient index. So again, this is where we actually are able to identify our patients. This is our patient directory. So the MPI serves as a link to the patient's record and, of course, facilitates patient identification. Now, because it contains master patient data, it's the key to proper patient identification. So, of course, it's critical for patient safety and quality of care because you can have patients with very similar names. You can have patients with very similar birth dates. And it's very easy to choose the wrong one when that patient comes in to the ER, especially if they're unconscious. There are a lot of situations where health facilities have chosen a junior instead of the senior, or you have a twin and you all have the same initials, and of course the birth dates are the same. Sometimes they will take a picture of you at a clinic or sometimes in the hospital, and if you're a twin, well, guess what? If you're identical, then they can't tell who is who. So it's very important to ensure that you accurately connect a patient to his or her medical information. So patient matching is very important because the long-term goal of the MPI is to maintain that longitudinal patient record, that information from birth all the way up until death. Now, dropping down into that section, I'm not going to read all this information to you, but it gets into the complexities of patient matching, especially when you have enterprise master patient indexes. So when you've got a large facility and you have this big integrated health system where you've got a clinic system and you've got multiple hospitals and patients could be seen in multiple areas, it gets a little more difficult. But it talks about the different algorithms that they use to help match up those patients. And there's 2 types listed over on page 193. You have deterministic and you have the statistical and mathematical. So be sure to read through that section. All right, let's drop down to health record retention. So retention of health records in any format involves storing the records, providing for timely retrieval, and establishing lengths of time that various types of records will be retained by the healthcare organization. So retain means how long they're going to keep them. All right, so let's get into storage and retrieval. Dropping all the way down to the paragraph where it starts with retrieval in the blue text. So, retrieval is quickly locating requested records and information needed for patient care and other uses. When a patient's record cannot be located, a provider cannot access medical information, and the patient's care may be compromised because of duplicate or improper treatment. So, if a physician doesn't have a past medical record to know, well, this patient was here in the ER last week and they had a CT of the abdomen, they may go and perform another CT of the abdomen. So, that's where we get into those duplicate tests and possibly improper treatment, because at that point, they don't know what has already happened. They don't know what the patient's previous diagnosis was. And so they may do something that's, contra indicates something with that patient's current diagnosis. Now, keep going in that section. Retrieval of paper health records involves checking out records from a filing area and tracking those that are not returned within a specified period. But so far, most of the time, we've moved away from those paper tracking systems and we're looking at EHRs instead. A software system can be used to track those paper records, but retrieval of EHRs includes automatic access or approval of a request and placement of the record in a work queue or a work list for the requester to access. Now, most of the time, if you're a physician and you're in an environment where there is an electronic health record, you don't have to request those records. Those physicians can see that patient's records because, again, that is part of TPO, treatment, payment, healthcare operations. So they don't have to have a request put in to get those old medical records, especially when you're in an electronic environment. All right, so let's talk about factors that influence our retention periods. Because the record is multifaceted with demands placed on it by many diverse interests, policies establishing retention schedules are critical to the record management process. So not only do you have federal and state laws that include statute of limitations, you have other legal issues that healthcare organizations must take into account, the requirements of external organizations like Joint Commission. And sometimes CMS, you have the Department of Health and Human Services, Office of Inspector General, and then of course AHIMA also recommends certain retention standards. Internal operational factors include emerging EHR technology, patient populations, institutional medical practice, research activity, educational needs, access to new technology, storage constraints or capabilities, cost, and your disaster recovery plans. Now, let's talk about the difference between active records and inactive records, and that's in the bottom of that paragraph. Your active records are those that are used regularly, meaning that they stay active. Now, it could be because that patient is still a frequent flyer. Let's say they come into your emergency room once or twice a week, depending on what their condition is. And those are the ones that get used the most. Now, inactive records are the ones that are not used often because maybe the patient is deceased. So you're not going and pulling their records, whether it's paper or whether it's an electronic record, because that patient is no longer coming into your facility. Or it could be that your patient is relatively healthy and they only come when disaster strikes. So maybe they have an ER visit once a year, or they come to the hospital for an outpatient test once every 6 months. So those are more inactive. All right, so let's talk about our federal and state laws. So all applicable state and federal statutes and regulations must be frequently reviewed and compared with one another to ensure that health records are retained for the time period required. Medicare requires records to be maintained for at least 5 years, including radiologist records. So that could be the printouts, films, images, etc. Home health agency records, long-term care records, your lab records, and any other records that document information about claims for reimbursement. So CMS requires 5 years. Many states recommend that patient health records be retained for 10 years following patient discharge or death. Special requirements for minor patients, we're going to get to that in more detail later, But some types of records, such as mammograms, may have retention periods up to 20 or 30 years. Now, source data records, so we're talking about fetal monitor strips, EKGs, EEGs, treadmill tests, other magnetic tapes, these can be incorporated into the EHR or maintained in their own department. So, radiology may keep all of the radiology films. Fetal monitoring strips are considered a part of the mother's record because the baby is not born at that time, so they do not have their own medical record number. But even though they're part of the mother's record, they still relate to the newborn, and they should be maintained for the same period of time that the newborn's record is maintained. So we've talked in the past, and we'll get into that for minors, but we're talking about the age of majority plus 7 years for the state of Mississippi through HIPAA. So let's continue on in that paragraph here. Okay, one interesting thing I wanted to point out is OSHA. OSHA requires that most health records of employees be maintained for the duration of employment plus 30 years. So, OSHA is the Occupational Safety and Health Administration. And so OSHA comes in and they do audits of your facility and they check to see how many injuries have been had by your employees and things like that. So if an employee gets hurt on the job, and let's say they touched acid or something in a lab or slipped in it or whatever would cause them some serious harm that OSHA would come in and look at, they want those records kept for the duration of employment plus 30 years because there can always be late effects or sequelas that come up in relation to those records. So that's why they want those kept for so long. All right, so let's get into the statute of limitations over on 195. So your statute of limitations is the time period in which a lawsuit can be filed, must be considered when we establish a retention schedule. So there's no one statute of limitations that has to be considered. So you have to look at it state by state and by the type of action being brought. So it could be a tort, contract, and we didn't really cover that chapter, so but that's not important. But just know that depending on what's going on and what state you're in is going to determine your statute of limitations. Now, although it must be given primary consideration, the statute of limitations for the types of lawsuits that concern a healthcare organization will usually be much shorter than the retention periods mandated by Medicare, patient care needs, and then many of the organizational's operational needs. All right, we do have two exceptions. So first is our minors, and then our incompetent individuals. So for minors, the statute of limitations, which generally includes those who are younger than the age of 18, may exceed the time for which health records are ordinarily retained. So if we talked about Medicare saying they only require you to retain records for 5 years, well, if you're a newborn, they're not going to destroy your records when you turn 5 years old. That's not going to happen. So a minor may file a lawsuit on his or her own behalf upon reaching the age of majority. So again, age of majority in most states is 18. Mississippi, we talked about it being 21, although that there is a bill going through to have the age of majority changed in Mississippi to the age of 18 as well. So the statute of limitations does not begin to run until the minor reaches the age of majority. So if the statute of limitations for the lawsuit being brought is 2 years, the minor would be able to bring legal action until they're 20 years old, if that age of majority is 18. If the lawsuit related to alleged medical malpractice when the child was 2 years old, the retention period in order to comply with this statute of limitations would be 18 years from the time the child was 2 years old or until they turned 20. So again, for HIPAA in Mississippi, we're talking HIPAA, I think, requires 7 years. That's their statute of limitations. So for Mississippi, with a age of majority at 21 and the statute of limitations being 7 years, that means every newborn that is born at North Mississippi Medical Center, their chart should be retained for 28 years. So a 27-year-old adult should be able to go to the hospital and request their birth records, and they should still have that information available for them. Now, your incompetent individuals, a state statute of limitations may also be extended for incompetent individuals who are deemed by court to have a mental disability that renders them unable to act on their own behalf, to handle their affairs, or represent themselves legally. Because a person's incompetence may never be lifted, so they may always have that disability, could be a developmental disability. Thus, the lawsuit can be filed at any time. An organization's record retention policy should specify that the records of these individuals should never be destroyed. Okay, so you have incompetent individuals. Sometimes it's hard to recognize just from a medical record that an individual is incompetent. So especially if you're in the paper world where there was actual destruction of paper records, you don't just have a flag on a chart to show that they were an incompetent individual. So electronic health records, as long as there are no space issues and you have plenty of storage, you should never have to delete or destroy anything. So along came the EHR, and as long as the organization could continue to create disk space so that they could save all of the information, then this kind of went by the wayside as far as your retention, because there were never any concerns with destroying paper because you ran out of space to file it. All right, dropping down to accreditation standards. So there are several entities that accredit healthcare organizations. We've talked about several of those, but Joint Commission is going to be the most often used example, and it defers to applicable statutes, regulations, patient care purposes, and an organization's operational and legal needs for determining their appropriate retention periods. So Joint Commission doesn't have a specified time frame. They look to the organization to determine what their retention policy should be. And therefore, when they come in, they are judging you on what you have in your policy. So whereas Medicare says 5 years, Joint Commission's saying, well, if you say 10 years, we're going to look and see if you still have stuff from 20 years ago, and if you do, great, but you better have this patient's chart because they came in 6 years ago, or this patient came in 7 years ago, and you better have information for this patient. Now, let's get into the AHIMA recommendations at the bottom of 195. So again, these facilities or entities, I should say, like AHIMA, they do not have any real authority. But remember, we talked about how they are perceived to have authority. So while they do not have force and effect of law, professional practice guidelines are valuable when it comes time to make operational decisions. And so if we flip over on to 196, we have their recommended retention standards. So for your diagnostic images, AHIMA recommends that you retain those for 5 years. Your disease index, 10 years. Your master patient index, keep it forever. That's a permanent thing. Your registry of births and deaths and surgical procedures, those are all permanent. Your patient health records for adults, they recommend 10 years after the most recent encounter. But if you look at that for minors, it's the same retention recommendation, 10 years after the most recent encounter. So AHIMA is not taking in consideration your statute of limitations for those lawsuits when they make their recommendations. Now, it says for operational needs, AHIMA recommends that healthcare organizations develop healthcare retention schedules that meet their organizational operational needs. So an organization, depending on its specific needs, may have legitimate uses that necessitate extending those retention periods. So again, it could be research, the cost of retention, education, and the inconvenience of purging. Because when you had paper records and you wanted to go purge those for microfilm or purge those for destruction, that was an intense job. So you would have to look at every single paper record to see what the discharge date was, know whether or not it was older than 10 years or older than so on. And then you'd have to look at the patient's birthday to determine how old they were, were they a minor, And then how did you know whether or not they were a competent or incompetent individual? So it was a very cumbersome process. Now, record retention schedules, drop down there. A healthcare organization must consider the previously mentioned factors when developing its health record retention schedule. Organizations may also decide to retain records for different periods of time based on the media types on which they reside. A retention schedule should specify what information should be retained, the time period for which it should be retained, and the storage medium. That's the format on which it is to be retained. It says retention schedules should address the transfer of health records from one medium to another, so paper to a scanned image. And we'll talk about this later in this chapter. Now, EHR retention. So a lot of decisions pertaining to the health record retention are determined by their existing record formats. Now, retention of electronic information is a complex task. So not only do you have retention guidelines that govern paper, you should have policies and procedures that specifically outline the retention of the myriad, because there is a myriad of electronic media types, because you can have images, you can have things on optical disc, you have things on CDs, you have things on DVDs, you have things printed off and boxed up and shipped off and put in microfilm. So in addition to health information, data inherent to EHR systems, such as your metadata, alerts, reminders, they also need to be addressed in your retention policy. This information is important for certifying the integrity of the record for business and legal purposes. Organizational retention requirements should be part of the selection and management of your EHR system. And then purging involves separating active records from inactive records in either a filing system or an electronic database. So I know several years ago when we had just transitioned off of our old, really couldn't even be called an electronic record, physicians could enter orders in the system, although it was cumbersome, and nurses did actually document in the system, but it wasn't a true EHR. When we transitioned to our actual EHR, they had a lot of documentation still in that old system, and our HIM department used that information. They could go print those old documents out of that system instead of having to go to microfilm and getting them. So anytime you can print something over having to go hunt down through microfilm, you better take the opportunity. Well, some of those records became inactive, and they actually went through and deleted them, especially if they were old enough to be outside of that statute of limitations, and they knew that we had them on microfilm. And that just made it so much harder for the HIM department, because again, instead of being able to print that document that took like 2 minutes max to find it and print it, it might take 30 minutes to go hunt it down in microfilm. And so when you get 20 requests a day for documents that may be 10 to 15 years old, that print option was a great benefit and a time saver. And so they kind of lost out on some of that. All right, continuing on in that paragraph, an organization must also consider record permanence in its retention policies. The life cycle of a software system is limited once implemented due to rapid advances in technology. Thus, information maintained in the EHR system is subject to technology changes or obsolescence that will impact its permanence and ability to be accessed. Procedures to protect data integrity during system conversions must be implemented and documented. A retention policy must factor in the projected life of the current system software. And in that bottom paragraph, that very first sentence there, other factors that should be considered when creating retention policies for electronic information are scanned images and your fetal monitoring strips. So, scanned images that have been fed into your document management system, they're not always of diagnostic quality. So your retention policy should state that the ancillary departments that created the information should maintain the information for the appropriate retention period. Basically, that means you scanning in something like a treadmill test. If you've ever seen a treadmill test printed out on paper, it's done on that glossy paper, and it's got those red lines behind it. And then your heart rate line is in a gray ink. And so when you scan that in, the scanner doesn't recognize it as color. And so it's all black and white, and the page is very dark. You can't see the line well. So what they're saying is because of that scanned image being scanned in and not being such a great quality, then the original in the originating system should be maintained for your retention period. And then again, your fetal monitor strips, they're not often compatible with your scanning systems because fetal monitor strips are like literally a book of paper. Again, it's that shiny, slick paper, and it's a continuous strip. Now, they have perforations where you can tear those off, but if you want a physician to be able to read it by looking at the paper, you better not tear those things apart. They probably want to rip your head off if you did that. So you keep it all connected, and it may be 30, 40, 50, 60, 70 little individual sheets all stuck together to make one long strip. So that's really not conducive to scanning. And so again, fetal monitor strips were something we fought with and we fought with and we fought with at North Mississippi Medical Center because we could not scan them in, and it cost us around $25,000 a year to send off maybe 2 years worth of fetal monitor strips to be put on a cartridge so that you could read those on a microfiche printer. And again, that's becoming a thing of the past. Before too long, there are not going to be any readers out there that allow you to even read microfilm. And so a lot of times, and one of our issues was the VP of General Counsel, he did not want to allow us to say that we could pull those strips from the actual electronic system because the vendor could not ensure that they could pull those strips up 28 years later. Because again, statute of limitations is 7 years after the age of majority. So if you have a baby born in 2020, you've got to be able to pull those records up to, so let's say 28 years. So if we add 20 years, that's 2040. And then we add the 8 years, we've got 2048 that this company, they could end up shutting their doors in the next 5 years. And so, of course, they cannot make any guarantees that you're able to go back and pull the information 28 years later. So that's kind of where we ended that, is they still microfilm the stupid pieces of paper. And I think Joy had told us at one point that they may have ended up pulling 2 fetal monitor strips in the last 20 years for a case. So, it's a lot of work, but legally you have to cover yourself. All right, so let's look at Check Your Understanding for Section 9.5. So number 1, a patient's PHR is a business record. I'm not sure why we're talking about PHRs in this section. PHRs were in the previous section, but that answer is false. All right, number 2, statute of limitations may not be considered when establishing a health record retention schedule. Well, that's absolutely false. You have to ensure that statute of limitations is in place when you're doing your retention schedule, because if someone can come and sue you 2 years after they reach the age of majority, then you want to ensure that you have kept the information for that length of time. Number 3, printing of paper copies from electronic health records should be encouraged because it allows more providers to access the information. And again, that was in our last section, 9.4, but that is also false. You want to restrict that printing because we talked about duplications. If they print out something from an electronic record and they manually document information on it, then, your integrity has been lost. Number 4, a master patient index is a directory of patient identifying information. You should remember that is absolutely true. That is how we identify our patients when they come into our facilities. And number 5, when establishing a health record retention schedule, an organization must maintain all records for the same time period. That is false. So again, we're not going to keep a minor's record for the same amount of time we keep an adult's record, and we're not going to keep an incompetent individual's records the same amount of time we keep a competent individual's records. All right, so that's the end of 9.5. We'll do a separate lecture for 9.6 where we start talking about health record disposition. So happy reading and happy study.